Now we are moving from Poland back to Norway and community treatment targeting people with severe mental illness. The next speaker is Erlend Bønes. He has a background in computer science with years of experience from the e-health sector. Erlend is a PhD fellow at our center, and his research brings important knowledge to the field of digital coordinated care. We look forward to your presentation, Erlend.
Thank you, Ellen. I will talk about my PhD work with the Flexible Assertive Community Treatment teams in Norway and the ICT challenges they face. First, about me, as Eirin said, I'm a PhD candidate here at the Norwegian Centre for e-health Research, and I have a master in computer science. I previously worked at the Norwegian Centre for Telemedicine and the University Hospital of North Norway. I will first say a bit about the background of FACT teams, Flexible Assertive Community Treatment teams. The background is the deinstitutionalization of mental health care that started in many countries, including Norway, from the 1960s. That the patients are no longer sent to an asylum if they have long-term serious mental illness. They are treated in the community. So there are various ways of working with a stronger focus on community treatment. In the US, they started with assertive community treatment in the 1970s. And I was looking if this was something that had been happening in Poland, and what I found that there was something equivalent called community treatment teams that started in the 1980s. The flexible assertive community treatment is a variant of assertive community treatment, and this method was developed in the Netherlands in the early 2000s. This method is better suited for rural areas with lower patient population, where there are not that many patients that have very serious long-term mental illness. And then the FACT model has been adapted to Norway, where are a lot more rural than in the Netherlands. So there were some changes in how, well, maybe the model wasn't perfectly suited for the Norwegian context. And there have also been some ICT challenges for the Norwegian teams that are there because of the way the Norwegian healthcare is organized. And I will talk about those challenges and what should be done. First, now I will talk about how the FACT teams work. They work with a patient group that have long-term, or they give long-term integrated care for people with severe mental illness, long-term severe mental illness. And the teams are multidisciplinary, and they're aiming to cover as many services as possible for the patients. So as much care and treatment as possible should come from the teams. And I have a picture here of somebody ringing on a doorbell. And the reason for that is that the team should go out in the community, meet the patients where they are, and give them follow-up and treatment in their social arenas and at home. The patients receive intensive follow-up in some periods, and in periods when they're more stable, they get individual case manager from one person on the team. And the teams, they have daily meetings where they have an electronic whiteboard where they go through the list of all the patients that receive intensive care. So the whole team is involved in the treatment of those patients and can coordinate how they are going to do it and plan further treatment. In Norway, the teams are members from both primary care and specialist care. And I'll come back to that. And in rural areas of Norway, there can be long travel distances for the teams, maybe an hour in the car for some of the patients. And in some of these teams, there are also several municipalities are part of the teams, so they are situated on different places. So in fact, in Norway, there are today around 70 FACT teams that target adults, and there are around 5 teams targeting youths, and more of those teams are being planned and will be implemented in the future coming year. And for several years now, the government have supported the ACT and FACT teams to kind of a startup funding where you can apply for funding for a few years to get the teams going. So in my PhD, I've been doing some data collection in 8 teams in total. 5 of those teams target adults, I was supposed to visit all 5, but this was during the COVID-19 pandemic. So in 2 of those teams, I only could do interviews on Skype for Business. In the 2 remaining teams, I visited them, looked at how they worked, did observations, and did interviews with team leaders and team coordinators. And later, I also did interviews in 3 teams targeting youth. One of the issues for the PAC teams in Norway is the electronic health records, or EHR. There are different systems in primary care and specialist care in Norway. And as I said, some of the PAC teams have members from different municipalities, so maybe the municipalities use different systems too. All teams that I visited use the system DIPS, that's for specialist care, and did the documentation there. So the people that are employed in primary care, they have to have so-called simplified employment or 0% position to be allowed to get access to the data. And they also have to use VPN solutions to get technical access to the data. So they have found a way to solve this problem. It's kind of annoying and cumbersome for the team to do this. And some of these teams, it varies a bit from team to team, but some of the teams have nobody or have no access to the EHR information from the municipalities. So then they would like to be able to access things like information about medication that they're given out by the municipalities. And they worry that if the municipalities cannot see what the teams are doing, do they then want to continue to support it economically? So they are worried about that. Another issue for the teams is electronic whiteboards that they use in the daily morning meetings. All the solutions that in the teams I visited were made in Microsoft Excel. And the teams wish that, and the picture here is an example whiteboard that the teams can use. And the teams wished that the whiteboards were either integrated with the EHR or a part of the EHR. And they find it kind of hard to use, and some information go missing if they move them from intensive care to case management, and so they are not really happy with the solutions they have now. Also, the patients in Norway have the right to access their own EHR information, and I would argue that the electronic whiteboard is a part of that information. So with how it works today, the patients have no way of no easy way at least to access the information in the electronic whiteboards, where they can use the portal helsenorge.no to access kind of their standard EHR. Also, I asked the EU teams about statistics, and they kind of want to be able to extract statistics from the use of the electronic whiteboard with how many patients with the different kinds of diagnosis. Another thing that was a bit surprising for me was that they also had some issues with the calendars, because they have several different calendars that they could use. They have a calendar in Outlook, and maybe those in specialist care have one version of Outlook, and in primary care have another version. And in the EHR DIPS, there's a calendar. So they have many different calendars that are available, but this kind of adds to the confusion. And the team leaders want a better overview of the teams, kind of have one place where they can see where the teams are. And one team leader said that the working they can change. They can have some plans, but then things change and they have to do something completely different. They want an overview of this. And also some team leaders are worried about the safety aspect. If the team members go out and visit the patients, they kind of feel safer if they know where they are, and they are not unsure about that. I also talked a bit with the teams about video consultations. 3 of the teams used video consultations successfully. They said they are not suited for patients, of course, and not in all situations, because these are patients with serious illness, many of them. But the 2 other teams said that no, they didn't believe that video consultation was suited for this patient group at all. But on the other hand, the 3 teams were happy with it, even if it was not, of course, ideal in all situations. And of course, the COVID-19 pandemic kind of increased the use of video with the patients, and for one team, they kind of started during the pandemic. This was mostly planned use, but there are also some examples of use in emergencies, where there was one situation where one team member was able to go to a patient who had a crisis, and then they connected a psychiatrist in the team on video, and they were kind of able to calm the situation. So, conclusion and further work. There are barriers for good ICT solutions for FACT teams in Norway. And then these barriers are mostly related to access to data and integration of data. So further research and better solutions are required for the FACT teams. So I've been publishing some papers. I have one in for review now that outline kind of the problems. I will publish more about what kind of solutions they will do. And I also delivered a requirement specification to the Norwegian Directorate of Health for how I believe an electronic whiteboard solution should be designed.